Hello friends, I'm here to share with you my ideas on social identity and public health. And for this, I wish to thank the organizers for bringing me on board for this purpose. We all perhaps have been made to believe that disaster and disease do not discriminate. This is what perhaps all of us have grown up to believe. And perhaps there is a truth in it. But then, why is it that children of some specific group suffer from diarrhea more than others? About 10% among SC, 8.1% among ST, as compared to 8.4% among other advanced communities. Why is it that tuberculosis strikes more among the scheduled castes, about 25%, a quarter of them, as compared to the other communities, which is, again, if I compare it with the advanced communities, about 20% of them are struck by tuberculosis. Does it have to do anything with the fact that more than 31% households have 3 or 4 persons sleeping in one room, reflecting on high crowding within the household? If this is interpolated with wealth, then most of these households fall in lower quintiles, wealth quintiles. Or is it because the first antenatal care is received from a doctor by only 40% of SC women, 33% of ST mothers, as compared to more than half of women from advanced communities? Well, these are some of the questions which we may wish to introspect. It may be of interest for us to note that prevalence of tuberculosis is highest among scheduled tribes, 1.07% for men and 2.63% for women, followed by scheduled castes, which is 0.74% among men and 0.4% among women. Among the other backward castes, it's 0.66% among women and 0.43% among men, as compared to the least when it comes to the advanced communities, 0.4% men and 0.39% women. Therefore, we see that the worst affected are the scheduled tribe women with 2.63%. It is more evident when compared to advanced caste groups, women in that group. Therefore, I think it's important for us to think about the tribal women's susceptibility to disease, vulnerability in terms of living conditions, which in fact corroborates the association with living conditions and prevalence of tuberculosis. Interestingly, unlike earlier rounds of the National Family Health Survey, the recent most, the fourth one, does not give prevalence data by social groups, while the data on knowledge and attitude by social groups is available. This deviation could be from the public health understanding that disease does not discriminate. But in this process of not collating the data, the personnel inadvertently end up discriminating by not processing the existing information collated through the survey. Nevertheless, as we move ahead, let me also point out that according to WHO estimates, in 2017, an estimated 2.7 million people developed tuberculosis in India, and over 400,000 people died in the same year. By WHO estimates again, India accounts for 27% of the global estimated 10 million cases and a quarter of the estimated 1.6 million deaths. The Global Burden of Disease Analysis estimated the number of incident cases to be 3 million for the year 2016. Now, let's compare this with the number of confirmed coronavirus cases of today, that is 13th April. Over a period of perhaps last 3 months, ever since we discovered that we've been affected by it, there are about 9,152 confirmed cases and 308 deaths. In this scenario, we need to consider, of course, the high infectivity and low fatality of COVID-19. This perhaps was a beginning for us to pose some uncomfortable questions. Ensuring health and well-being of people has been the concern of governments all around the world. The Constitution of India decrees health as the responsibility of the state. It makes every state of the nation responsible for raising the levels of nutrition and standards of living of its people and improvement of public health as one of its primary duties. The Constitution assigns states the predominant responsibility of provision of health-enhancing services, and along with the central government, the state governments have to come on board to execute this. However, these efforts to materialize these goals have encountered many barriers. Access to any public service, including health, is the outcome of awareness, information, knowledge, and conducive environment to use these services. A conducive environment is likely to be created when the infrastructure is available. The health personnel is empathetic and sensitive towards the needs of the users, and the users have the propensity enabling all of this. However, contrary to the very purpose, the environment is conducive to some, but not for everybody else. And this we get from literature which has emanated through the 70s, 80s, 90s, and 2000s, and even now. Health-seeking behavior is determined by economic propensity and health infrastructure as much as by social identity of users and providers of the healthcare services. The attitude of users and providers, which, if devoid of empathy and sensitivity, is likely to affect the access. And this again is evident from many papers, research which have come out now. If this sensitivity and empathy does not exist, it becomes very difficult for equity in health to happen. Inequalities are, as we know, socially unjust, and they're also inequitable. In health, inequality is examined as differences in prevalence and incidence of illnesses among people across social groups. It is often defined as the absence of systemic and potential remedial differences in one or more aspects of health across populations disaggregated by social, economic, demographic, and geographical characteristics. Health equality, therefore, is treating equals equally and ensuring equal access to those in equal need of healthcare. Provisioning of health in this framework is based on need rather than propensity to pay. Another framework requires to treat the unequal differently. The rich people should pay a higher proportion of their income for accessing care or health care services as compared to the poor. A third dimension incorporates the benefits of public subsidies for healthcare services. The health status differs on the basis of income, education, occupation, place of residence, gender, ethnicity, and religion, in addition to many other axes that we may want to add on. There is evident association of low health status with poor, women, rural place of residence, tribal populations, and of course, the Dalits and other minority groups. Despite improvements in health indicators since independence, the gap across social group remains wide. Therefore, the need to revisit policy implementation, regime, and environment to health equity, to ensure health equity, is important. As we know, India has been a signatory to Alma Ata Declaration, Health for All, and is committed to moving towards universal health coverage. In the light of Sustainable Development Goals, too, health is a major concern which intersects with all other sustainable goals, which endeavor to leaving no one behind. And therefore, all states necessarily have to take on board health as their priority. All the more when we are amidst such a health crisis, which is unprecedented as of now. Going by this understanding, if we look at the literature, we see that studies, however, show some very contrary pictures. Access to healthcare services appears to be far from equitable. And if I quote from an ethnographic study based on observations and in-depth interviews in Minakera village of Bidar districts in Karnataka, which was undertaken by a young colleague in a different institution, it is evident that caste impacts the interaction between public health service providers and care users. It's interesting to note that the findings of this study corroborate the work which I did about 15 years earlier in western parts of the country in 11 villages of Gujarat and Rajasthan. Nothing seems to have changed in these years as far as access to healthcare services by Dalits in rural India is concerned. The caste-based social identity manifests itself formally and informally in the public health system, functional at the grassroots level in the villages. As regards basic infrastructure, civic amenities, asset ownership, and interpersonal interaction, caste discrimination is obvious as well as internalized. The electricity connection and supply, brick roads and pathways, drains and drainage, use of building material, all are better in non-Dalit quarters as compared to Dalit residential spaces. The better endowed health facility are used by the non-Dalits, while the ones with poorer facilities are left for the Dalits. Most providers of the healthcare service in the villages are non-Dalits, and we know this fairly well. As we remind ourselves, both as providers and users of healthcare services, that disaster and illness do not discriminate, subtlety and justification for discriminatory behavior seeps in. Social identity, especially caste-based discrimination in healthcare provisioning, happens when the doctors and nurses refrain from touching a Dalit patient during diagnosis, display indifference and apathy in behavior, and often cut them short when they would try to explain their ailment. Contrary to this, a non-Dalit person normalize the discriminatory behavior of service providers and do not attribute this to any kind of caste discrimination. They are given enough opportunity to explain their ailment. They are spoken to with a lot of dignity and care. In this context, both those who are using the care and those who are providing the care believe that this kind of behavior happens because of the uneven platform of knowledge on which the user and the provider stand. The caste-based differential treatment of healthcare users is often imperceptible and thus is paid less consideration. But it needs more attention because it hampers equitable health services and puts persons who are requiring care at risk. Such is the scenario in general in everyday access to healthcare. What will be the case in the times of health crisis, such as what we are experiencing now, is anybody's guess. What was announced as a measure to break the chain of the spread of COVID-19 has disparaged in more than it was anticipated or even imagined for that matter. As the economy continues to reel under the pressures of demonetization and GST, the bombshell of a lockdown descended on whole of India at 12 midnight on 24th March and has triggered many problems. Reigning supreme is the fear of getting infected and stigmatized. getting appropriate and adequate treatment in the care centers, uncertainty in case of emergency other than corona-induced, and anxiety to reach the care center and get care. The other ancillary issues are lockdown-stimulated joblessness and consequent problems of staying or reaching home, closure of educational institutions, and stress and anxiety due to all of this. As always, the worst hit is the poor and the vulnerable, most of whom are the scheduled castes and the scheduled tribes. These are the ones whom earn their livelihoods from unorganized sector, informal sector, which together constitute more than 75% of the total workforce. Closure of work units have devoid them of work and thus the daily bread and the propensity to pay the rent for their dwelling units. Without work and money, they have been finding it difficult to survive in the cities they adopted as their karma bhumi. They have little choice but to start walking towards their respective native places. Paradoxically, they could neither stay in their karma bhumi nor could move out due to the sealed borders. Reports of their plight are doing the rounds, from getting killed due to exhaustion, to running over by a vehicle, to being queued up like prisoners and sanitized by sprinklers like the crops. Disregarding the WHO advisory, which explains that spraying alcohol or chlorine can be harmful for the clothes as well as the mucous membranes in the body and is not known to kill the virus that have already entered the body. Additionally, the closure of small and medium enterprises has affected money, but most of all those who are at the lower ladder of wages, those who are self-employed or working in informal environments in the entertainment industry or in part-time work with zero-hour contracts where the employer does not have to provide regular work for the employer. But the employee has to be on call in case they are needed to work. Most of them, as we all know, are from socially disadvantaged communities. Persons depending on agriculture for their livelihood are unable to move. The agricultural field that could survive the rains are waiting to be harvested. If not harvested, the loss incurred to the farmers, to the agricultural laborers, the mandis and the arhatiyas will spill over to the common man who need their daily supplies. Who will buy and sell the produce when there are mandis closed? Will e-Kisan enable transportation of produce? And even before it's harvested, the prices of commodities will inevitably dance to the tune of the vicious cycle of the high demand, low supply. This will further create limits to accessing other resources and services too. In all this, the landless laborer will be the most affected, and we know what is their social identity of an overwhelming majority of them. We must also think about the daily wage earners. Most of them again come from socially disadvantaged backgrounds. How can they remain within the homes? How will they live by staying home? Most of them constitute the workers in small and medium enterprises. What are the plans for the SMEs to cope with this kind of abrupt closure? And very importantly, when there is a Prime Minister's Relief Fund already existing, what is the need of a new entity, PM Cares? How will the contribution to this will be different from PM Relief Fund, and why? It is imperative to seek answers to these questions as they are important in our war against crisis, which no more remains within the limits of health, but has spanned out to economic, social, and environmental spheres too. While the Ministry of Labour and Employment on 20th March announced economic measures to safeguard jobs, guaranteed wages, and support the self-employed White Letter DO number 101108-220, There is ambiguity about how these measures will be implemented and how people will manage to take care of the loss of income. Human costs of the pandemic ranges from death of acquaintances, friends and family to physical effects of infection and the mental distress arising due to the fear of almost anything possible. This crisis has started displaying its effect on economic, physical, psychological well-being as against increasingly anxious, unhappy, self-centered and lonely societies. It's important for us to note that no person affected with coronavirus is socially untouchable. The need is to be kept at a distance from others so that the droplets caused by coughing or sneezing do not reach the others. Therefore, it is physical distancing, 1 meter apart, that we need to observe to keep the virus at bay. We in India practice social distancing fairly widely since long, and in a different context in which the phrase itself is highly discriminatory. We are socially distant from and critical of each other on the basis of religion, caste, region, language, ethnicity, color, age, residence, gender, economic status, etc., despite the constitutional safeguard professing the alternative. Therefore, there is need to change the phrase. Even the World Health Organization from 20th March 2020 has started to call it physical distancing instead of social distancing, a term used largely by epidemiologists to convey maintaining physical distance. Most of them situated in Western Hemisphere have been unaware of the social distancing which is practiced in the Indian subcontinent, given the social stratification we are engulfed in. That perhaps is the reason for using the term even in the earlier times of Spanish flu during 1918. Restrictions on movement and appeal for social distancing have created an unknown fear leading to fright, anxiety, and therefore panic. When people are unsure if they will be able to access the necessary protection or care, or that they may run out of provisions, which can lead to panic buying, in fact, further stressing the market, which needed to assure the supplies for those who needed it more. Sudden shortage of sanitizers initially and the mask perhaps is a very good example. Addressing the health needs is urgent and non-negotiable. However, in unequal India, this may be of most difficult task even when it is made to be believed that disease does not discriminate. We need to remember strictly that system in its element does. Persons at the airport are screened with respect while the migrant laborers are sprayed with disinfectant, queuing them up in the herds with their hands up as criminals. And what about the persons engaging in sanitation, waste picking and garbage collection, its transportation and disposal? Their work allows them very little option to wash hands as frequently as perhaps the government advisories suggest, including staying at home. Some institutions decided to stop the sanitation workers from door-to-door collection of garbage on their premises, but had to withdraw the orders within a day. Most of them are migrants and are employed by urban local bodies and private firms. Most of them are poor and hail from Dalit communities and live in squatters and slums where availability and storage of water itself is a concern. Their plight is twofold. They deal with garbage and filth and they are exposed to viruses, bacteria, poisonous gases, and are also vulnerable to accidents and have little that they can do to practice the kind of personal hygiene is being propagated. For them, bathing is needed. Hand wash is not enough to do away with the lingering stench of the filth from which they eke out their livelihood. More importantly, they need to use the masks and the gloves for their work, even without the COVID-19 scare. In the times of this crisis, they are all the more necessary for them. They are hardly seen using these basic safety gears. Forget about the more sophisticated one, which such workers in other countries are supplied with. Is it because they overwhelmingly come from Dalit communities while the medical professionals do not, and therefore the former's lives are less valuable than the latter's? Given the graded inequalities in which we are located as Indians, a careful investigation is essential. Another unfortunate spin-off is the rage evident on the Dalits for assumingly not adhering by the Prime Minister's call to put off the lights on a designated date and time in an incident which was reported to have occurred in a village called Pingor in Haryana on April 5. To ensure healthcare access among the vulnerable populations, it is the prerogative of the state, since the financial burden of curative care is higher among lower income groups, most of whom are Dalits. In the last 70 years, India has achieved considerable improvement in health of its people. Nonetheless, the gap across social group remains wide still. There is evident association of low health status with poor, with women, rural, tribal, scheduled caste, and even minority groups. Therefore, the need is to revisit policy environment and implement so as to ensure health equity through socially conscious public health. And this becomes extremely important, particularly if you relate to the scenario which happened in China itself. On 31st of December 2019, the WHO China country office was informed of cases of pneumonia of unknown etiology detected in Wuhan city, Hubei province of China. Subsequently, on 9th January, Chinese authorities reported in the media that the cause of this viral pneumonia was initially identified as a new type of coronavirus, which is different from any other human coronaviruses discovered so far. The WHO had sounded the global community in January. On 14th of February, our Ministry of Health and Family Welfare said that till then the situation was under control and the assurances were given in the coming few weeks too. But a little over a month later, everything went amok. And therefore, the preparedness for an event such as this could be something which is called for, and therefore investing in public health for a country like ours becomes inevitable, particularly to ensure what the Sustainable Development Goals call for, leaving no one behind, even in context of health, particularly in conditions such as a pandemic coronavirus. Thank you.